questions about. How do you measure, right? So I had a couple of people ask me, interestingly, in the last 2 weeks, how do we even do the audits? Well, first of all, it's to let you know that what we're presenting today is just some kind of foundational knowledge for you. You will not get all the answers today, but you will get quite a few answers that will lead you down the right path. So first of all, I'm going to tell you a story. I'm sure most of you have heard these stories before, those who read Hans Christian Andersen's books. But as I was preparing this webinar, this story came back to me, and I think it's relevant. I want everybody to find themselves somewhere, in the characters in the story. So there was once a king in a kingdom who loved clothes, and thought he was the best thing after sliced bread. And his love for clothes was known all over the kingdom and everywhere. So everybody knew him. He was very, very vain, right? So he thought he was the best. So one day, 2 shysters came into his kingdom and said, we want to make you some very, very special clothes. Nobody else has anything like this. Nobody else. And these clothes, it's only those who are knowledgeable and those who are of high pedigree will be able to see these clothes. And we will make it of the finest silk. And we're going to turn gold into threads and use it to make the clothes. Oh, the king was very happy. He was very happy indeed. I mean, he was going to have something nobody else had. So he got silk, threads, and gold for the shysters to start making the clothes. And they set them up to start making the clothes. So these shysters, of course, put the threads and all the silk and everything in their bags. And then they sat at the loom and they were making all the right actions, all the right movements, as if they were weaving the cloth. So after a couple of days, the king sent his trusted advisor to go and see what these guys were doing. And when they got there, the shysters said to them, can't you see how beautiful this is? Can you see the pattern? Can you see this? Can you see that? And this advisor is thinking, oh my goodness, I can't see anything. Does that mean I am not wise? Or does that mean I don't have high pedigree? I'm not going to let anybody think that of me. So he then said, oh yes, this is beautiful. This is really beautiful. And he went back to the king and told the king everything is coming along quite well, knowing in his head that, I can't see this. And then the king sent somebody else and the same thing. And then the day before the cloth was supposed to be ready, the king was going to wear this cloth for a parade, for a parade down into his city. He went himself to see the cloth. And these guys were like really, very, very busy. And he got there and he couldn't see anything. And he thought to himself, oh my goodness, if I say I haven't seen anything, my people are going to think I am not wise. They're going to think I am not of high pedigree. So he said to them, oh, beautiful, beautiful. On the day of the parade, the shysters came carrying, pretending that they were carrying a lot of things. And then they asked him to take off his clothes. And then they put this imaginary cloth around him and told him the part of why it is so special is that you really can't even feel the weight. And then the king begins to go on his parade and everybody's clapping because nobody wants to say they can't see. They don't know what's going on. So everybody thinks I may be the only person that can see that there are no clothes here. So I better keep quiet. And so they continued, the king continued in his birthday suit down the middle of the streets until a young boy put up his hands and said, my goodness, the king is wearing no clothes. And then everybody's like, oh, really? The boy said the king is wearing no clothes. Yes, but I can't see no clothes either. I can't see no clothes either. And at this point, everybody's like, oh my goodness, the king is naked. And the king himself really could not afford to tell people that he was naked. He kept going down the streets. So we had a king parading down his kingdom in his birthday suit. Now, I want every one of us to find ourselves somewhere in that story. Are we the king who would rather not hear the news, or rather not own up that I can't see what's going on here? Help me. Are we the people who the king sent, and we look at it, and because everybody else is saying it, this is all good. Oh, we are doing very well. Our organization is doing really, really good. We keep quiet. Or are we the little boy who's going to say, hey, come on, wait, I don't think we're doing so well. Can we try and take a look at this again? Find yourself in there. So the key questions for today: why is measurement so important to quality? And the thing there, is that it's the first step that leads us to understand and control and eventually improve healthcare, the quality of care that we're giving. We say if you can't measure something, then you don't understand it. You really do not know what's going on. You may be the king who is parading naked just because he doesn't understand. If you can't understand it, you cannot control it. And if you cannot control it, then you can't improve it. In other words, if you can't measure something, you cannot improve it. Okay? So the next question will be, what should I measure? And how do I measure it? Now, measurement is like, when you do measures in a hospital or in any healthcare setting for that matter, it's like having a car dashboard that helps you see how you are doing. At what speed are you going? What's your fuel efficiency? Do you even have fuel? How well are you doing? How well is the organization doing? How well are our physicians doing? How do our patients feel about the care that we're providing? Okay, so it allows the providers and the organization to understand what's working well and what's not working so well. And then it allows us to analyze and find areas for improvement. There are three types of measures. For most clinicians, especially the physicians, they're more used to research. And one of the things that happens every time I work with physicians is you get a pushback because they're asking you how significant, what's the level of significance, what's the level of statistical significance, what's the p-value of the data that you're showing me? I don't accept it. All right. But there's a difference between the data that we use for research and the one we use for accountability, which is what, again, many of us are used to, and the one that we use for improvement. I am not going to be talking about improvement and research today. We want to, first of all, even understand, how we're doing. So looking at data for quality assurance and for accountability. All right. Now, that data is the one that we're going to be collecting. Most times you try to collect about all the data around any specific issue as much as possible. Yes, you may occasionally do sampling if you have huge amounts of data, but you want to collect as much data to understand how the system is performing as possible. You want to be able to reduce bias, and that's why you collect quite a bit of data. And this is the data that usually we present to our accreditation bodies. We use it, the government asks for it, which is part of the accountability, right? Now, there are different classifications of indicators. So you look at rate-based indicators, which are usually ratios, the percentages, or per 1,000 live births, or per 1,000 patient days, per 1,000 bed days. And this is versus the simple count. The simple count is when you have to count every event because they're significant. So things like the sentinel events, the never events, you do not skip them. Every single one is important, and you may actually have to work on every single occurrence. Then we have the generic versus disease specific. So the ones that are for hypertension, right? So you want to measure something for hypertension or for diabetes, or you want to measure something that's for all inpatients, which is more generic, or all outpatients. Then we have patient-based indicators versus event-based indicators. So patient-based indicators, how long did the patient stay in the ER versus, what is the waiting time in outpatient or inpatient or something. Then we also have indicators that are based on the dimensions of care, and we'll look at them very briefly soon. You know, the 6 dimensions of care we usually talk about from the Institute of Medicine: safe, timely, effective, efficient, and patient-centered. Then we also have the one that's used mostly, which is what we call the Donabedian's trio, where you look at structure, process, outcome. Now, more importantly, there's a way that we overlap these in a way to give us good information about our organizations. Donabedian's trio is the one that we use mainly, like I said. So you look at structure. What are the things that the organization, the organization's capacity to provide care, the conditions that exist. So you look at buildings, you look at staff, you look at equipment, you look at IT, right? Those are the structures that we need to have in place to enable us do the things that we need to do. So the processes are the things that we do. The services that we provide, how do we provide it? Are we doing the things that we said we will do? So those kinds of measures look at, how often we do our checklists, how well we prescribe, how we do things, how we provide services. And the outcome actually measures the result of the work that we're doing. So it said that outcomes is, the structure and process is what gives us the outcome that we want to get. So things like blood pressure control will be a clinical outcome. Patient satisfaction is an outcome that we desire. Financial performance will be an action. So what are the criteria for choosing our indicators? There are quite a few. I will not go through everything for time, but I've put them here because we're going to send the slides to you and you can go through them. But you have to think about how relevant this criteria, the indicator is to your organization and to your setting. You have to make sure you contextualize. Don't just pick up an indicator because it's being used somewhere and begin to look to use it. How well is it relevant to your organization, to the effect it has on the health and your health expenditure? How important is it for your relevant stakeholders? It's no use measuring orthopedic only indicators when you don't have orthopedic patients or orthopedic surgeons, right? What's the potential for improvement? If you cannot improve, if that data is not going to help you improve anything, then it's no use measuring it because you may end up with 1,000 indicators if you're not careful. So why should we be measuring buildings, the number of buildings we have, if we are not in the process of adding more? Why are we measuring the number of beds we have, except we're talking about functionality, if we are not adding more or if we cannot improve on it? What's the purpose and context in which that indicator was initially developed, right? So I look at indicators around what, continuity of care. And, in Canada, we used to measure the time it takes to send discharge summaries to the primary care consultant. But in a lot of establishments in Nigeria, for instance, where the primary care sits in the same department, in the same building as the inpatients, you're not sending anything anywhere. So you are not going to be measuring how you send. So think about your context. And then can you measure, and in what time frame can you collect the data? If you're going to be collecting data that is occurring once in 9 months, you want to think about that. Or if you're not going to be able to get that data on time, within the required time frame, you want to think about it. The meaning of it. And then does it really give you information about whether quality of service or care is low or high? You need to consider all that. You need to consider the need of your stakeholders, as I said, and I have listed some of them here. But your stakeholders range from the government, because you're submitting measures to the government, data to the government, all the way to the citizens who want to know how well is the care that we're providing, your patients, your physicians, other professionals in the organization. Okay, so you look at their needs. Then you need to know that each of these indicators have their strengths and their weaknesses. They're not all good. They're not all perfect, but all are good. So you need to think about what it is that you want to provide, right? So structure indicators, for instance, are easy to collect. Usually they're easy to count because you can see them most times and you can report. They're verifiable. But at the same time, the link to quality can be pretty weak, right? So is it just because you don't have a building that the outcome is not so good? All right, so you need to think about all that. Then, for processes, they're easily available. You can count easily, but how salient are they? And then it said that the process measures are the ones that seem to encourage professionals to try to game the system, especially when they're linked to payment. Okay, and then of course the outcome measures. So what are the sources of data that we have in healthcare organizations? We have our administrative data. The administrative data seem to form the bulk of the data that we collect. So you get information from billing, all the registers that we have. So inpatient registers, theater registers, registers in the emergency room, registers in the stores, in the pharmacy, a lot of registers. Then you have your log risk registers, incident reports, a lot of those. Those are the administrative data. Then the medical records form another major source of data. Then you have disease-specific registries where we have to send data to, whether they're cancer registries, HIV registries, and things like that. Then, of course, survey of healthcare personnel, and then direct observation. Many times we have to go to the Gamba, as we say, go and observe directly to be able to get your information. Again, for each of these sources of data, their strengths and weaknesses. I will not go into them. They're here for you to see when you're ready to review the, how to get your data. Now, for the domains of quality, we know them, the 6: safe, timely, effective, efficient, equity, and patient-centered. When you want to think about what kinds of data should I be collecting, it is best to think about them from the point of view of the quality domains, right? So if I want to know whether we're providing effective care or appropriate care, what kind of data can I look at? So you can look at clinical indicators. You can look at benchmarking indicators. Your morbidity and mortality meetings, reports will provide you with a lot of data. Audits against international standards. So clinical audits against, professional standards, international standards. For safe, when you're trying to find out whether your care is safe, you look at things like adverse events, sentinel events, other clinical indicators, and all that. For patient-centered as well, collecting your patient satisfaction data, waiting time, accreditation reports will also give you some of this data. Same thing for efficient, timely, and structures. These are all sources of data that you can collect. Now, I've developed here something that's useful for me, what you call a quality matrix. So what I've done is to look at the domains and the types of quality indicators. So for safety, you could actually have structure, process, and outcome data. For effective care, you look at indicators of structure, process, and outcomes. Now, it's important to note that your indicators do not have to stay the same all the time. Once you start collecting indicators and there's evidence that you have done well, you have settled. So if, for instance, you now have 100% across board when you're collecting these indicators for a year, then you may want to drop that indicator and pick up another set of indicators so that you can continuously improve. So this is something I would encourage you all to try and develop. Look at the domains of quality, look at whether, what you're collecting in terms of structure, process, and outcomes. The other thing that I would encourage you to do is to look at it per department, right? Each department should look at what are our structures, processes, and outcomes that are enabling us to provide quality in all the domains, because you can't be doing well in one area and say you're doing well with quality. Quality is about all the domains, all the 6 domains. So each department can pick this, pick one of the metrics like this and then go on and populate it to help them understand the quality of data, the quality of care that they're delivering. When you develop indicators, when you pick indicators, you have to understand all these, what you call the operational definitions. If you do not, then you may find out that in the same organization, in pharmacy, in lab, you're collecting hand wash data, for instance, hand hygiene data. And you may not be able to compare your data because your definitions are off. You can't, you're comparing apples and oranges, as they say. So when you are going to use indicators, you need to do something like what you see here. You must define your indicators. You must define your numerator, your denominator, and all the other data fields that I have put in here, because that is what helps you to collect reliable data. Otherwise, the data, like Julia had said earlier, the data may not be usable or may not be providing you the information that you really need to be able to make a difference. Okay, there's some available databases that you can actually pick indicators from, because a lot of work has been done in many jurisdictions around, what are indicators that help us really understand the care that we're providing. These are just a few that I have picked, which you can go look at later. Okay. So how do you report data? There are many ways of reporting data, but you need to report data in a way that will be useful for the organization. So one of them is the dashboard. This is what many of us use. And dashboards can be quite useful depending on the level to which you are reporting to, what we call the RAG, red, amber, green, right? So this data, kind of gives anybody who's looking at it an overall picture of the green seems to be a bit more than the red. So, okay, maybe we're not doing too bad. But how do you even determine what's red, what's amber, what's green? There are no standards across the world. So it makes it difficult for you to benchmark. But for the purposes of getting information in the hospital, in the organization, whether it's hospital, primary care, it gives you some kind of indication about how you're performing, right now. Now, this is one way not to do it, because even though it's blurred on my screen, it's because the source of the data, it was so jam-packed that we really couldn't see all the lines in there. So if you want to send indicators, please, use the RAG. Please try to space it out in a way that even though you're trying to convey the colors, at least the person who is reading can still look at what the indicators are. Then there are other ways to look at, to present data. You look at the pie charts, you look at the bar charts, you look at the histograms. They all have indications for use. So the histograms, for instance, will tell you about the spread. Do we have normal distribution? Are we skewed to one side or the other? Scatter plots will help you look at relationships, right? So is the waiting time related to the satisfaction, or is it not? Are we getting poor satisfaction because of waiting time? Maybe not. So you're able to use scatter plots for that. The Pareto charts help you to understand what are the vital few things that are causing you issues or you want to focus on. So you may want to use Pareto charts. But more importantly, this is what we advocate for in quality, that we use time series to help us understand the performance of our hospital over time. How well have we been doing and how well are we doing currently? The time series also helps us relate specific incidents, changes to the performance, to improvement in performance or worsening of performance. Time series data is the preferred mode of reporting data, especially if you want to see whether there's an improvement, you want to be able to detect whether there's a deterioration, there's a change. As you know, every change, every improvement requires a change, but not every change is an improvement. So when you want to make changes, you want to see how the changes that you're instituting in your organization, whether it's because your strategy has changed or something, it's best to use the time series. Okay? And there are two types. There's the run chart and there's the control chart. The control chart, because of the statistics that's been involved in building the control charts, they are more sensitive to change and helping you detect whether what you're doing is what is causing the change or not. Okay, so more importantly, when you're doing visual display of data, you need to be sure that you're presenting the data in a way that's accurate and easy to interpret. And your asset test, as it said, is what does it show? Right? What are we seeing here? My people know, I always ask, what are we seeing here? What's this showing us? That's the question you want to ask yourself. If you can't answer that question, or the person that you're showing the data can't answer that question, you want to go back and review how you have presented that data. And always tell the truth. We can make data say anything we want. You can make it tell any story you want, but make sure that your data is telling the truth. Do not be the king or the king's advisors that are not telling the truth. Now, as I round up, I think it's important to note that the data is not all it is. It's not all important in itself. It is the response to the data that's most important. Okay, so while deciding what to measure and how to measure it, it is equally important to determine the reaction to the measurement once we have it. You cannot fatten a cow by weighing it, as the Palestinians will say. So just collecting data is not going to improve quality. You have to respond to the data. You have to react to the data. Use it. When you analyze it, let it inform decisions that are being made in the organization. So thank you for listening.
Thank you so much, Ajibike. I think this was very educative presentation, and we get a lot of positive feedback that our audience likes the presentation in the chat. We are happy that you like it. And I just wanted to sum up and give you a few highlights before we move to the next speaker. So personally, when I try to explain something to medical facilities, I like to use various comparisons. And sometimes it's not easy to persuade medical facility and staff in the departments to get data and to measure indicators because they think it's bureaucracy, it's useless. So now Dr. Ajibike explained the importance of measurement, and I think I can compare measurements to diagnostics, lab diagnostics and radiology diagnostics. Patient looks healthy, still he complains about something, and we need to check whether the patient is as healthy as he looks. So we sent him to a CBC test, and CBC test is an equivalent, is actually measurement of indicators, and it tells you whether you are doing as good as you expect, whether you are as safe regarding patient care as you expect, or something may be hidden from your eyes. When you do the indicators measurement, you see it. Second important point that Dr. Ajibike mentioned, statistics is not for the sake of statistics. It's really taking a lot of effort to measure, to get certain data, but it should tell you something. So the rule number one is that indicator is always a proportion. We saw medical facilities that measure kilowatts of consumed energy. So what? What is your target consumption of energy per month? If you compare what you really use, then you can say whether you are doing, where you're meeting your target or not yet, or you are actually doing even better than you expected. So it can never be absolute figure. It's always a proportion. So be careful when you decide what you measure. It's really diagnostic, so it should tell you something. By the way, I also wanted to mention that today's webinar is actually a part of our mini series of webinars on measurements. So today we're talking about the indicators and give you examples of measurements. Next time we plan to talk, during our next webinar, we plan to talk about measuring clinical outcomes specifically. And then we plan to talk about how to benchmark, how to compare yourself to other hospitals, department to department, and all the specifics of that. And now we move to the next speaker. That is Dr. Anand. I'm happy to introduce Head of Quality from Manipal Hospitals, India. Dr. Anand, the floor is yours.
Thank you. Just give me a moment while I share my screen. I hope the screen is visible to all of you. Good morning,
Yes,
good afternoon, and good evening. Can I get a confirmation? Is the screen visible to all of you? Okay.
We get confirmation in the chat. It is visible.
Thank you. Good morning, good afternoon, and good evening. We have got participants from Canada to Afghanistan. I was looking at the chat box. Namaste. In case you're wondering what is this word, that's the traditional Indian greeting to all of you. And I'll be sharing with you over the next 20 to 25 minutes an experience from India, specifically from Manipal. And how am I going to be structuring this talk? I'll begin with a brief introduction of what Manipal is all about and our journey in quality. The large chunk of time would be spent on sharing with you 12 tips and tricks. And I'll be concluding the talk with some concluding remarks. So very briefly about Manipal Health Enterprises. We are almost 60 years young now. Our founder started the first public-private partnership medical college in the country way back in 1953. We have grown now, and we are now the second largest hospital group in India. We have more than 7,300 beds under us, and we touch at least 4 million lives. Our strength is in our doctors, who are approximately 4,000 in number, and our employee strength is more than 10,000. Ladies and gentlemen, that in a nutshell is Manipal. Our journey in quality began almost 2 decades ago. Way back in 2000 is when we really started the journey of quality. And at that point of time, it was this wonderful standard called as ISO 9001-2000. Many of you may not have heard about it, but this was the forerunner of many of the basic quality management systems. So we started our journey in ISOs, and that's when we really started our first steps in identifying, monitoring, and analyzing indicators. Over the past 2 decades from ISO, we have moved on to national and international accreditations, and we have developed our own indicator matrix. So the next part of the talk is focused on sharing our experiences and telling you as to what you could be doing, how you could also overcome some of the challenges. What are the things that you could use to ensure that your journey is smoother than our journey? The first tip, very similar. I'm taking a cue from what our previous speaker said. Why are we measuring these indicators? What is the purpose of measuring these indicators? Why do I need to capture this data? How is it going to make a difference? Let us be very, very clear about the purpose of measuring these indicators. Unless we have a clarity on why we are measuring this, we will end up with a situation where everyone keeps measuring, and the end result, unfortunately, tends to become a big zero. We do not want that, and therefore be very clear about the purpose as to why you are measuring these indicators. What do I measure? 1966 is when Donabedian came up with the structure, process, and outcome, and Ajibike has touched upon this in her talk. I'll go to a step further ahead. What should you actually be measuring? Should I focus on the structure-based indicators? Should I focus on those process-based indicators? Or should I focus on those outcome-based indicators? Let's understand a very simple fact. There is no use in measuring processes that do not affect outcomes, or outcomes that are not affected by processes. A word of caution if you try and identify structure-related procedures. Though structure-related procedures, indicators tend to be relatively more easier to capture, they are the more difficult ones to change. Ask your hospital head to increase the head count. Ask your hospital head to increase the budget. Ladies and gentlemen, easier said than done. So be extremely careful when you look at structure-based indicators. When it comes to process and outcome, I would go by what Charles Shaw said in 1998, and I quote, "If you measure outcome, you won't know how you got there. And if you measure process, you might not know what happened at the end of it," unquote. Ladies and gentlemen, it's therefore very, very important to have a right balance of the process and outcome related indicators. Dr. Ajibike in a talk gave you a quality matrix as to how you could use that, how you could map it out to the 6 domains and see where it fits. And that's a good tool that I suggest you use. In our system, we tend to largely focus on process and outcome related indicators. A rough proportion of mix is we have got about 60% of process related indicators, 35% of outcome related indicators, and only about 5% of them are structure related indicators. One of the other things that you need to keep in mind is, at what level am I monitoring this indicator? Am I going to be monitoring this at the level of the department? Am I going to be monitoring this at the level of the organization? Or like in a large network like ours, we have got 27 hospitals. Am I going to be measuring this at the level of the network? Because that decides on what indicator you will measure. You could have different indicators for departments, organization, and at the network. Always do keep in mind any requirements from external agencies. And what are these external agencies? Typically, they are the accreditation or the certification bodies. Many of these accreditation certification bodies have their own set of requirements when it comes to the indicators that you need to capture, and you need to definitely keep those requirements in mind. My third tip, again, drawing from what Dr. Ajibike said, create a template of how you're going to capture the indicators. Hope you remember the surgical safety sort of template which Dr. Ajibike showed in a talk. First and foremost, define the terms. We tend to think that we know. If I ask you what is a fall, we got close to 267, 68 participants now in the webinar. I will not be surprised if I get at least 20 different definitions for the term fall. Imagine if you do the same thing in your organization. If there is a mismatch in the perception of what you think a fall is and what someone else thinks a fall is, you will end up measuring the wrong parameter and come up with the wrong values. So wherever it is required, define those terms. Wherever you have got time blood, if you're, say, monitoring the response time for something, clearly define the start time and the end time. Do not assume, do not presume. Please spell it out in black and white. Obviously, for an indicator, you will require a numerator and a denominator. And the third part of that is a multiplier. It could be, there could be no multiplier, or it could be 100, 1,000, because the multiplier is dependent on the unit of expression. It could be a percentage, it could be per 1,000 patient days, so on and so forth. So that's the reason as to why you need to have this unit of expression. This is the template. This is the template that we have in our organization, what we use. This is a simple sort of an Excel sheet, done in Excel sheet. You will notice that we have defined the indicator. We have given as to what is the reference for that. We have given certain definitions as to what needs to be there, how frequently it has to be captured. Do you need to do sampling, or sampling is not applicable? How are you going to express it, so on and so forth? A simple template like this done in a simple Excel sheet would give a lot of information to the stakeholders. The next tip, decide on whether you want sampling, and if you want to, if you're going to go with sampling, what is the sample size going to be? It's always a good idea to stick to the principles of biostatistics because that is what we have used. In a large organization, it's not possible for us to capture. Let's say I'm looking at the waiting time in the outpatient department. And as you saw, we touch close to 4 million outpatients in a year. It's not possible for me to monitor each one of them. So I would use a sampling strategy. I'll use a stratified sampling strategy. And we have defined the sample size based on principles of biostatistics. And again, what have we done? We have put this is based on the running average of the previous 3 months. The stakeholder just has to input the values of the previous 3 months. The sheet will automatically calculate the value and tell you the sample size. And this column actually gives you as to what are the indicators to which this particular sample is applicable. Nothing high technology, a very simple tool that you could all use. The fifth tip, I think this is something which all of us keep pondering about, and I'll not be surprised if you find a lot of queries on this particular aspect. Should I capture data using physical formats? Should I use an electronic format? Or should I use a hybrid format? Which is better? Ladies and gentlemen, there is no definitive answer. It depends on your organization. You know what works best in your organization, stick to it. We use a hybrid model in the sense that a lot of our indicators are captured physically. That's by manual review of the records, so on and so forth. There are quite a few of these indicators which are captured automatically from the hospital information system. That's what we mean by electronic system. Be aware that the system is not foolproof. It depends. If you are going to rely on your system, ensure that the data is fed in properly. Otherwise, there's no point in having an electronic system if the raw data is not going to be put. And that's the reason as to why I say you will have to decide as to what works best in your setting and accordingly use it. We, in fact, use a lot of electronic things for a display and for reporting aspects. This is how we have got a web portal dedicated for quality indicators. We call it as the Q-MAPN. MAPN is actually an acronym for the Manipal Performance and Assessment Network. MAPN in the language which is predominantly used in India also means measurement. So there's a reason as to why you're labeled in that manner, where the quality leads of the various units are given a username and a password. This is how they log in. Once they get to log in, they've got 3 options wherein they can calculate the sample size. They have an option of entering the data point into indicators, and there's also a visual description of how the data looks. And I will show it to you in subsequent slides. So you remember I showed you the Excel sheet earlier. This is the same thing on the portal. So again, the person just has to input the values of the preceding 3 months and the value gets automatically populated. It also gets populated in the denominator of the indicator automatically. There is no human intervention which is involved. We collate data on a monthly basis. So every month, the quality lead sort of keys in the numerator and the denominator. In some instances, the denominator is already auto-populated. There's no option for them to change it. They cannot override it. It is the system which gives you the data. So you input the numerator and denominator, and the value of the indicator automatically comes into place. Do not forget verification of data, because we rely so much on these indicators. God forbid if there's an error in the data. This error could be in the way it's captured, or it could be in the way the data is entered. So you need to set certain sort of alerts as to what are the conditions when you will verify. So we look at the data of the previous months. We look at the trend. And when we see an outlier, we would definitely go about verifying the data. And that for us is a condition that we will use. How do we go about verifying the data? We ask for random raw data sheets. We speak to the concerned stakeholders and we try and figure out as to how the data has to be corrected or what needs to be changed. Importantly, the stakeholders are also informed as to what is going to happen if there's a data mismatch. We need to compare apples with apples. Therefore, it is important that we have data in a uniform manner from all our hospitals. So we do tell them that, look, for this month, we'll unfortunately not be able to use the data that you have provided because it seems to us that the methodology has not been followed. So please go back, work on it, and come back to us so that we can use this data for a useful purpose. So that, ladies and gentlemen, is the 6th tip. Ajibike touched upon this in our talk, the visualization. It's not, if I keep telling you values after values after values, you will all be bored. It has to be visually appealing. This is our dashboards. This is how we go about visually depicting the data. And we use the speedometer with the RAG or the traffic light system, as I say. Our indicators are broadly classified into 4 categories: clinical, infection control related, managerial, and patient safety. We have a way by which we calculate the composite scores. Anything about 90%, we say you are in the green zone, good to go. Anything between 80 to 90, we say, look, there is a warning sign, you are in the amber zone, better watch out. Below 70, we tell them that, look, you are in the red zone. You need to actually pull up and ensure that the speedometer moves towards the right. So that's the way that we go about visually depicting the data. And clicking on any one of these, say the clinical infection, gives them the next thing, which is a more detailed thing in which they can see the data of the previous 3 months. It comes as like a bar chart. It gives them the value of the numerator, the denominator. The benchmark is specified to them so as to how it looks. The same thing, if they want to see the past 6 months data as to what they need to see, it comes in this manner. So it's easily visualized for them, so it becomes easier. And again, there's a color coding at the bottom which tells them that they are on track. They need to sort of keep a watch, or they need to actually take some course correction. And this is how we have gone about visualizing the data. Again, you could do this using your Excel sheet. It's not necessary that you need to develop a portal. An Excel sheet would also provide you the same sort of options that exist, and you could use that. The next tip, what I would strongly advocate, is come up with benchmarks. And I think there's going to be a series of webinars, and one of the webinars will touch upon benchmarks. But do keep in mind as to how you go about setting about benchmarks. What we have used is, we have used our own historical data. We have used national and international data to come up with our benchmarks. For infection control, we use the CDC NHSN as a benchmark. Similarly, for patient falls, we have got another benchmark. So for each one of those indicators, we have set our benchmarks. And again, those benchmarks are not just for external, it's also internal benchmarks. You may recollect that we have got 27 odd hospitals in the network. So we also provide them with a description as to how they are compared to other hospitals in the network. How are they performing? And this is how you would look. You will notice that there is a line here at the top which indicates as to what is the benchmark for that particular indicator. This gives them the running sort of the month to date, the peer average as to how they're looking at. Similarly, you can do it for the year to date, so on and so forth. That's something that you all need to keep in mind and what could be used so you follow in this particular aspect. The 9th tip, and one of the most important tips, is analysis and improvements. Ladies and gentlemen, analysis and improvements are the foundation on which we are building our edifice of quality. It's important that this be an important measure for which we are capturing the indicators. And I quote Peter Drucker, quote, "If you can't measure it, you can't improve it," unquote. And as a corollary, I always say, if you don't improve it, why measure it? What's the point of measuring it, spending those innumerable number of man hours trying to capture the data? You need to do those improvements. And to come up with the improvements, you need to do an analysis. One thing that we all need to remember is that there would be a month-on-month variations. Don't jump just because there's an outlier in a month. What we follow is we use a 3-month data period. If a particular indicator is not meeting the benchmark for 3 consecutive months, that's when we actually start asking our hospitals to do a deep dive, come up with the root cause, find out as to what's happening, and come up with an improvement project. That's the measure that we follow. In this entire process, do remember, communication is the key to success. With whom do you need to communicate? You need to communicate with all the stakeholders. These are the people who will be capturing the data. These are the people to whom you will report the data, that is to the managers, or it could be the top management, to the hospital directors. So you need to communicate with them. You need to communicate to them as to why are we measuring these indicators? How are we measuring these indicators? What is the benchmark? What is the basis for that? All these should be a part of your communication. This could be communicated either through internal meetings, through newsletters, through mails, or having a town hall. It's left to you as to what works best with you, and please use that strategy. In today's era, mergers and acquisitions are the norm. Everyone wants to expand. A small hospital wants to become big, and a big hospital wants to become bigger. You want to go across geographies. In all these, do not forget that if you merge or acquire with another hospital, you need to start integrating the methodology for data capture. You need to be ready as to how you're going to manage a situation when you take over another hospital. When we had a similar situation, what we did was we checked the strengths and opportunities. What are the similarities? These are the low-hanging fruits. The data methodology, the capture methodology is the same. The indicators are the same. These, ladies and gentlemen, are the low-hanging fruits. Start with them. Make that as a beginning. The difficult ones, the points on which there is no consensus, leave it for a later date, but do take it up. You need to prioritize as to what you will be taking up in phase 1, phase 2, and maybe what you will take in the end. And that's an important tip that you need to remember when you're integrating data. The last tip that I have for you, ladies and gentlemen, and this is based on what, again, Donna Bedian said, and I quote, ultimately, the secret of quality is love. If you have love, you can then work backwards to monitor and improve the system. Like in any marriage or any relationship, February 14th is around the corner. You need to keep saying, I love you. So very similarly, you need to keep revising your indicators as established intervals. What is the interval? You decide. You decide what works best for you. But do remember that you should at least review them once a year. Review may end up with a revision, or there may be, you may feel that, no, what you're doing is fine. There is no need for us to revise. That's perfectly fine. At least you would have reviewed it once in a year. That, ladies and gentlemen, were the 12 tips that I wanted to share with you based on our experience. So to conclude, please remember, a substantial amount of resources and research in the last few decades have been spent on assessing and improving the quality of healthcare. We have made considerable progress in developing measurement tools, and there are widespread applications. However, variations in quality and safety problems persist even after adjusting for those confounders. There's a lot of increasing interest in what works. Everyone wants to know what works and use that as a stepping stone for developing their own things. So what I would want to say is, start simple and develop it as you go along. Please take everyone on board, involve all your stakeholders, and the most important tip, listen, listen, and listen. Listen to your stakeholders, listen to your patients, listen to your administrators, listen to what they have got to say, because that, ladies and gentlemen, is the reason as to why we need to ensure that we capture these indicators. Let me conclude with a Chinese proverb. To get through the hardest journey, we need to take only one step at a time, but we must keep stepping. Ladies and gentlemen, I request each one of you to take those small baby steps so that we start going from strength to strength and strengthen the whole process of capturing indicators and monitoring those indicators. Thank you for a patient hearing.
Thank you so much, Dr. Anand, for your very useful and very practical tips. Thanks a lot for sharing the Manipal experience, which is really precious because we want to improve knowledge sharing. And this is really the value that, that is difficult to find, to hear from other hospitals, how they were working along this journey. So lots of useful tips. I don't think I have enough time to repeat them. I just wanted to stress once again the importance of visualization because it helps you to see whether you are in the green zone or in the yellow zone, amber zone, or red zone. And this is what Dr. Ajibike said. This is what Dr. Anand said. Then also verify, because you rely on your data. And actually, we're getting lots of questions on how to make sure that the data collected is accurate. And we're going to discuss it during the question and answer session. By the way, definitely we will be staying a little bit longer today as usual, because we get so many questions and just we have such wonderful presentations. And now I will introduce the third speaker, but before we move to the third speaker, I also wanted to make an important statement that lack of IT system is not an excuse not to measure. And this was an example Dr. Anand made, because often we hear, oh, when I have some time IT system, I'll be measuring. Now I'm all paper, so I cannot. Everyone can measure, even if you're 100% paper, you can do it manually. It's not an excuse. So now we move to the third speaker, Aafke Graaff, Head of SafeCare, PharmAccess. Aafke, over to you, please.
Thank you, Julia. And give me also one moment to share my screen, to share the presentation. So is it visible?
Yes, we can see.
Okay, perfect. Okay, good afternoon, good morning, good evening, because like Dr. Anand said, there are a lot of people in this call, and I'm very happy to be able to talk here today about how our experience, SafeCare's experience with why, how, and what to measure with quality. And if you, based on the data, how do you use them most effectively? Well, we thought in the order of these presentations, it was nice to make it to go from to more practical. So what I will be showing you today is first, of course, the short intro, but how we measured quality in the past pandemic. And we, of course, had a lot of experience, everybody in the world during COVID-19. How did we measure quality and how did we use the data? The learnings of our pandemic response and how that also influenced our assessment approaches. How we prioritize data, how do we analyze them? And of course, I will end with some take-home messages as well. So to start with a short introduction, PharmAccess, which SafeCare is part from, is a Dutch NGO founded 20 years ago by Dr. Joep Lange. And he was a fierce advocate of equal access to antiretroviral therapy. And that's what PharmAccess now stands for as well, equal access to healthcare. With a few pillars: access to finance, health insurance schemes, and quality, what I'm responsible for. And we do that through a combination of digital innovations, and with all our interventions, we look at the research and analytics. And SafeCare is a standard-based methodology. We heard from the previous speakers, of course, a lot how to measure it. SafeCare has standards, 170 to 680 standards, how advanced you would want it to be. And they cover all the medical to non-medical aspects of care. So it goes from HR to inpatient to laboratory, the whole wide holistically of quality of a healthcare organization. And because we're talking about quality, SafeCare was founded or started 12 years ago. And over the time, of course, there were a lot of changes. We started, of course, with the paper-based on-site assessments, grow towards digital on-site assessments. And I will be taking you along that road during COVID, how that changed it. And we are focused on emerging countries. I'm also today in Zanzibar. So there you can see really how they implement it very well and how we can help them with providing solutions to grow. It's really about inspire and to focus on progression. So you start at a certain level of quality and we provide you with a quality improvement plan, but also with practical solutions, how you can grow in your quality. And with that, again, as Dr. Anand also said, you need to focus on the ecosystem, from policymakers to stakeholders to payers, and provide transparency on the data. A little bit of our experience in those years, we have done more than 9,000 assessments in all of these countries, you can see in this slide. And yeah, then COVID hit in March 2020. And of course, everybody needed to quick pace adopt and adapt all their practices, because it was really, well, of course, Africa was a little bit behind of the rest of the world. So we had a little bit of time to change, because our main focus is on Africa, to really prepare and help healthcare facilities prepare. With our main focus, I need to shift this a little bit, avoiding facility-based infections and spreading of COVID-19. And we did that by providing guidance and practical up-to-date information. At first, manually, we went to the facilities, and later digital. And we combined that with, of course, the data that we have a little bit of a technical problem, sorry for that. By providing the data that we measured with stakeholders. So for example, we're working with a lot of healthcare organizations, network organizations, who were very interested how they needed to go along during COVID. How did they, what kind of resources were missing, what processes were missing. And those data that we gathered from the healthcare facilities, we could share them with that to make it an integrated approach. And of course, we were looking at triaging, PPEs, oxygen, all the things that are important in an epidemic like COVID. Like I said, at first we started with some practical, this is not the core of this presentation, but I thought it was nice to show a few visuals. We provided healthcare facility with these checklists, these measurements that were paper-based, provided them with PPEs, with soap, and posters like you see here with some practical information and translated in a few languages, what you can see here in Kiswahili. I would like to make it, to show you shortly the app that we developed after that. Because of course, at the moment you can see, I hope you can see the screen of the telephone moving. Because of course, at some point, lockdown started. So we could start in the beginning with on-site assessments, measurements of quality. And at a certain page, that wasn't possible. At certain moments, we couldn't leave the offices anymore. So we developed this self-assessment digital tool based on the self-assessment tool that we already had. And we developed it with input from behavioral scientists, because how do you use quality on a distance, or how do you measure quality on a distance? And we really looked at behavioral aspects in that. How can you make it most truthful, but how can you also make it most motivating to show people and facilities why they should use, why they should focus on quality, like Julia already said, at some point people think it might be useless, but if you show them why they need to do that, that will really help. So we also, in this tool, you might have seen it included information, practical information, did you know questions, a checklist on PPEs, and also a process and structural assessments that facilities could answer on the moment that they were available in their facility. And the data, of course, it gathered a lot of data, and the reality of COVID preparedness, of course, you've heard of that, was in many areas of the world wasn't optimal. And as you can see here, this is just one visualization. I will go later into other visualizations. But what you can see here, that, for example, infection prevention policy was missing in 50% of cases. That isolation areas, the main important things, that if you can see what do you want to measure, those are very important things. Oxygen supply was missing in 50 to 40% of the facilities, and pulse oximeters as well. So these data were really important to be used, and were also very happily used by the network organizations to really drive decision and target their resources. And I think if you look at how do you use data and with whom do you share it, this system approach really, even in this COVID, even made us realize more how important that is. To finalize this part about the impact, I have some nice statements here. Improving quality-wise for a space that never gets filled up. And the platform they found useful because it opened their eyes about things I haven't put in place while I thought my facility was ready. So we got some very positive responses. You can also see that it was used in many countries in Africa and that many facilities used it. So this made us rethink our assessment and measurement approach. Because what we saw was that in a moment during COVID, what do you need? What were our learnings? But what we found as well for building this resilience is that you need data flexibility and timeliness. And you can do that in a really easy way by going digital, because you cannot wait for 1 year to have the data to do research on before you, because of course you need to have quick actions. And policymakers, it can inform policy data. Providers are often at remote areas, and with digital tools, you can really provide them with up-to-date information. So how did this going forward impact our assessment and measurements approaches? And what you can see here is that we found that it was really incentivizing. We found that many healthcare facilities used the tools, and that they also filled it in quite truthfully. We did some comparisons between facilities that we did on-site assessments and self-assessments, and we found that there was a 20-point difference on a 100-point scale. So there was a difference, but it was really useful for mapping, for informed decision-making. And so we really, with this epidemic, we could learn that it was a valuable tool, whilst at first we didn't think it was. So with that, we redefined, reimagined our approach with a more blended and balanced approach of on-site assessment, self-assessment, and even because the capacity building also during this epidemic needed to be remote, that we also changed to remotely supervised assessments with for example, QI officers doing an assessment with an assessor, a trained assessor, virtually available. And of course, if you look at what do you measure, how do you measure progress? We also developed tooling for that. And of course, I know the audience doesn't have this tool, but again, and I will also show you data, we use these tools. We can also share this with the people here in the audience, the self-assessment tools. But it's really about visualization. I was this morning in a clinic in Zanzibar where they used a whiteboard where they visualized all their indicators. And just by seeing it, it really motivates you and it also helps you. So it's the visualization doesn't need to be digital. So just as a remark. How we use within SafeCare the measurement of progress, we use that via an app where healthcare providers have an app that they can use with benchmarking data, with gamification elements like badges, where they can, in which we hope to motivate them to use, because of course it's not about measurements, it's about how to improve, and that's what we're learning together, how we can help healthcare facilities around the world realize how important quality is. I would like to show you a video about that. Let me see. Do you see my screen or not?
We can see the first slide of the presentation.
5 million people.
Okay. Sorry, I think I...
Some 5 million people die
Did
every
it start now or not?
Yes, it is always working on the sound. Yeah.
Thank you.
year because of poor quality of healthcare, causing more deaths than those caused by a lack of access to care. For healthcare professionals in low and middle income countries who are committed to bettering their services, the challenge of enforcing quality standards and facilities can be daunting. Therefore, there is a need for data insights and practical guidance on how to improve. What can SafeCare's quality platform do for healthcare professionals? The SafeCare Quality Platform provides practical quality improvement guidance to healthcare professionals in low and middle income countries. The intuitive digital platform tracks performance progress and provides simplified analytics and dashboards for decision making all in one place. Here's how it works. After a healthcare facility gets a SafeCare assessment, they can log in to the quality platform to track progress. When a quality improvement activity is completed, a photo can be uploaded and the task marked complete. Performance progress can be monitored remotely using a real-time dashboard. This dashboard also gives quality data for networks of facilities because as a healthcare stakeholder, you want to know how facilities are performing. The quality platform provides you with exactly the type of insights that you need to make data-driven decisions, so you can measure your progress and prioritize interventions and investments. Join the community of healthcare stakeholders using data tools to improve care quality.
Okay, that was one of the tools. I want to go back to the self-assessment because that is a different way of measuring. And I think I put the URL down. If people would be interested, they could try it at home or at their facility as well. And of course, we defined what do we need to measure. We changed from COVID, where it's clear what is very important, but what do we measure of general quality. And what we did is that we linked our indicators of our broad holistic methodology to literature that has an evidence-based effect on health outcomes. So we chose those 45 indicators which have the biggest effects, and of course with looking at holistically. And use that within these self-assessments, which we have learned that were very useful. They're efficient, they're low cost, they can reach remote areas, they're scalable, and they're customizable, as you can see here. If there are network organizations here, we can help you with customizing it. So what did we measure? Well, these are some examples, and as you can see, we chose here the categories: leadership, human resources, patient assessments, information and education, emergency care, lab and medication, infection prevention and control, equipment and infrastructure. And of course, this is also based on the Donner-Medium structure that the other presenters were talking about. Some examples about the triage process. If you look at patient assessments, the triage process, is there licensed clinical staff? Are there regular reassessments? Are there national, international clinical practice guidelines? Are they used? And are there diagnostic images services? And of course, this is very broad for a facility, but it's also a practical way to see what you're missing and to see what you are improving. So to round up the last two slides, where you can see how we visualize the data in those self-assessments and how you can really easily see by visualizing where the gaps are. You can see here, for example, these are for the self-assessment, some data. I used the example of the patient assessment of the slide before, where you can see that patient records, for example, very important indicator and a driver of quality, is lacking in a big group of facilities. So that would be really something to target your interventions on. And also infection prevention and control, which we all know is very important in your facility. with PPEs and staff hygiene and training. If you are a senior, if you are a senior leader within a hospital, you can see where you need to target on. And also, if you're a policymaker, you can also target your resources. And on the ground, you can use the QIP to really also improve and see where you are in your quality journey. So to round up, for me, what really was a learning was that self-measurement of quality is fairly truthful and can really be used for informed decision-making and mapping of quality. That healthcare providers are motivated to measure their quality. And that's of course what we know. And it's also really about behavior. Yeah? I think the people who are here in the audience today, they want to know how they need to improve quality. And if you have the right tooling, and that it is not easy, but it makes it more easy if you have this tooling. And how do we accelerate this? By partnering and an ecosystem approach. We all need to work together to improve the quality overall. One of the latest learning is that we really found all the input of quality-related input, experience sharing, the experience that were shared, really valuable, of continuously improving, as we all need to improve in this ecosystem. So for that, if there are any additional questions, this is my email address below, but thank you very much for listening.
Thanks so much, Aafke. Wonderful presentation. Thanks a lot. And I think this is actually a great example of how flexible measurement should be, because of course, before the COVID pandemic, we were not thinking about this criteria that Aafke mentioned, and we didn't think about this measurement. But measurement being a diagnostic tool, this was a great example of adapting the measurements for the situation to see what needs to be improved. There is not enough oxygen. Obviously, we need to provide more oxygen. So remember that measurement is a diagnostic tool, and it will help you to choose the right indicators. Bear in mind, you will not make a knee CT scan for a patient who is complaining of toothache, right? So think what you need to diagnose, and it will help you to choose the right indicators. Now we're moving to our question and answer section, and we're getting so many questions today that I don't think we will be able to address all of them during this session. However, the good thing is that our experts kindly already replied to some of the questions which were asked in question and answer section, so you can read the answers there. And also we will definitely be posting questions and answers, most popular ones, in our community on practice on Facebook. So if you haven't joined yet, you're welcome to join it, and you will be able to ask more questions to our experts or find answers to the questions that you already asked. And now we would like to start with the first question, which actually we received a little bit earlier from one of the hospitals that we are working with, a hospital from Uganda. But coincidentally, today Aafke repeated this statement several times during her presentation, to make informed decisions. So what we wanted to discuss as the first statement, how to connect data analysis to informed decisions. What are the efficient ways? How to make it really work as 360% degree approach, that you analyze, you collect data, analyze, and then it gives you some information, and then you make these informed decisions on improvement. What our experts can advise on this. Aafke, maybe you can be the first one.
Yeah, thanks, Julia. Yeah, I think it's really about choosing the indicators that you really value the most. Where do you want to focus on? And I think what we have seen is that if you choose your indicators right and you really focus on them, it will help you focusing your strategy. And for that is really, what learned me the most during the past years.
Thanks a lot. Dr. Anand, any advice from you on this? How to connect measurement to informed decision-making?
Nothing much to add, but one specific thing that I would want to say is, I'll go back to what I said earlier. What is the purpose? Why am I capturing this data? if you have clarity on this important question, it will automatically get sort of matched. However, if you're not clear as to why am I monitoring, okay, let me monitor this, let me monitor this, let me monitor this, then we'll end up with a situation where no one knows as to what am I going to be doing with this. So I think if you want to see the benefit, we need to answer that first critical question as to why am I capturing it. That's the only thing I would want to add.
Thanks a lot. Thanks a lot. Very useful. Ajibike, anything from you on this?
The only other thing I would add is a commitment to the measurement and to improvement. So as Dr. Anand has said, you have to know why you're capturing it, but you must be committed to wanting to use the data for improvement. That way you're actually keeping an eye on it. The run charts and the Shuhad charts have rules, right? About, when it triggers something significant and whether you've made an improvement, it may be an improvement, it may be a worse thing. So if you're committed to making improvements and you're, keeping an eye on your data, then you will know when to act and when not to act, or you have certain rules. But more importantly is that commitment to wanting to make an improvement and not just collect data to tick the box.
Thanks a lot, Ajibike. Now it's going to be a tricky question, actually. It's quite clear if the management asks you to measure and then asks you to analyze, because that's what they expect. But what if you measure and analyze upon your own initiative in the department, and then you want to tell the manager that something needs to be changed? How to bring leadership on board and again, make this culture of informed decisions if you measure yourself and the management doesn't support it?
Julia, if I may, I just want to say this again from experience. We have had this situation where a department comes to me and says that, look, we have monitored this and this is not happening. And the reason it is not happening is because you're not given me this, and this. Unfortunately, it starts becoming used like a tool for my wish list. I want this, therefore I have gone about capturing some data to prove what I wanted to show you, and then I come with my list to the management. No management is going to be willing to accept this, because the very intent with which you started is something which they would doubt. So I think it goes back as to why am I capturing this data? So if you want to do it, have a discussion, I would say, with your management. Tell them, look, I have got an issue. I feel that the problem is because of this. However, I would want to go ahead. I would want to measure it, and I would want to come up with some concrete data. Do you have any suggestions? That's what I keep telling. Discuss with the stakeholders. Don't come and show them results in the end on the face and say this has to be done. It will never be done. So having that communication with the top management at various stages is a definite way to ensure that the top management listens to you in the end. Thank you.
Thank you, Dr. Anand. Very useful. Ajibike, Aafke, anything from you? Any tips on bringing leadership on board and not trying to manipulate?
Yeah, so that's the word, not to attempt to manipulate. So I guess hopefully, if the staff and the management have the same vision. So first of all, the leadership has to ensure that the staff understand the vision for the hospital or the healthcare facility, and the leadership themselves are committed to the vision. So everybody is aligned and you're going in the same direction. That is usually very helpful because it then looks at what are we measuring. But it's also important to let the staff know. You see, you can measure many things, but we can't do all things. There's a limitation on resources. So you actually need to think and prioritize what needs to be measured. If you come to your leadership with things that are impacting safety, impacting what's important to them, so patient experience, patient safety, efficiency, cost, right? You will be able to show with good intent that we need to change this. And be patient. I mean, imagine that just about every department has 2 or 3 or 4 things that they want changed, right? Buy into the vision, work as a team to see which one should we prioritize. That way, it's a win-win for everybody. But if you come knocking on them, like Dr. Anand said, just because you want to prove a point, everybody's going to be unhappy. You'll be unhappy. Management will be unhappy.
Thanks a lot, Ajibike. Aafke, you wanted to say something as well, I saw.
Yeah. No, I think it's really about that shared vision, but also understanding or explaining why it is important. I think with important indicators, it should be possible, but that should be understandable also for the management. And if you have the visualizations, if you have the data to underscore the importance, you can also, of course, come up with practical solutions yourself. And you don't need to go to 100% to impact patient outcomes already. You can also say, we prioritize this. It's very important, but if we do it that way, if you have a practical solution, it will also impact patient outcomes already. So really be smart at taking your interventions.
Thanks a lot. Very useful advice. Then again, actually tricky question. Often we are asked, how is quality converted into efficiency, financial efficiency? And Ajibike mentioned cost. So one of the questions we received is actually how to align and how to connect measurements in quality to financial measurements. And is there any connection? And should there be any connection really? What advice can you give regarding these measurements to our audience? Who would like to be the first?
Yeah, I could start.
Yes,
I think,
please.
Of course, finance is part of total quality of a healthcare facility. Yeah, if the finance department, if the accounting isn't working, you cannot buy the stock that you need to use for a facility. So it should be an integral part. And I think it's all about getting medication, being able to pay your doctors and your nurses. So it is a very important factor to look at and also to keep on measuring and see how you can improve that.
Thanks a lot. Ajibike, yes, please.
Yeah. Cost is related to quality because, I know that doctors like to have the latest and, the shiniest, brightest tools with singing and dancing and all that. But that doesn't necessarily provide the best care, right? So we really should be looking at, when you're talking about quality, it's value, right? The outcome by the cost of it. So you need to, and like Aafke said, you have to keep your doors open. So if you're spending a lot of money and you're not getting the value for what you're spending money on, then you may end up having to close your doors. And that's not necessarily quality. So it's something that we need to look at. And when you're looking at improvements as well, you can actually look at your return on investment, right? So you're investing in improving care. So some things you have to have. If you, like you said, if you don't have oxygen, then you don't have oxygen. There's no alternative for oxygen. You must invest in getting that. But in some other improvements, you look at what's the cost versus the outcome and the benefit of that. And you can look at the return on investment. Sometimes it's not worth the dollars, but you also then look at what you call dark green and light green dollars. Dark green dollars in the sense of whether it actually gives you a financial return. Does it hit the bottom line? But sometimes it's light green dollars in that you can see a savings that you cannot relate to money at the end of the month, but may actually lead to increase, reduced length of stay, improvement in experience of the patient, which may eventually lead to, more income for you, but maybe not at the time that you're doing the initial investment. So think about that in terms of returns on investment. Is it worth paying so much to get whatever your outcome is?
Thanks, Ajibike. This is excellent. Yes, Dr. Anand.
Yeah, I think another question, a very similar question that I'm asked always is quality a cost center or a profit center? I think that's the thing, because everybody tends to think that quality is a cost center. We tend to do that, do this is required, that is required. But if you start, that's the process. You look at the outcomes. If I'm able to reduce the A loss, if I'm able to reduce the healthcare associated infections, I reduce those pressure ulcers, I reduce those falls, I reduce those litigations. Suddenly people start realizing quality is a profit center. There is a financial angle to quality. It makes a lot of business sense. It's just how we look at it. We need to look at it from a different perspective, because we tend to only look at a part of it and then say that you people in quality only ask us for resource. Show me the benefits. A simple answer is, please tell me what's happened to the ALOS. How has your bed turnover increased? Have you been able to treat more patients now? How many litigations have you saved? And that's when we start, if you start measuring all those, then we realize that yes, what Dr. Anand or what the quality people are saying makes a lot of sense. And that's how measurement of quality indicators gets linked to the financial performance. Thank you.
Wonderful. Wonderful point. Thanks a lot, Dr. Anand.
Yeah, can I make one
please.
final point? That's also how we call it, the business of quality. What we see also, the same as Dr. Anand said, is we see really patient numbers improve. And it's also with our healthcare providers, really a USP, a selling point. I do want to improve quality, but I also want to improve my business.
That's a great point, Aafke. Thanks a lot. So next question is actually very practical. Can you please describe what are the common mistakes while gathering a lot of data and analyzing a lot of data? So maybe these are some lessons learned from your experience so that our audience can avoid that and do it right from the very beginning. So if they collect lots of indicators, big data, big hospital, lots of departments, what mistakes you would expect in such a case?
Okay, Julie, let me start with our own experience. When we started, we are monitoring more than 120 indicators. Yes, you heard it right. 120, triple digits. And my dashboard looked much worse than what Dr. Ajibike showed in her presentation. Thankfully, she never got to look at my dashboard. There was hardly anything to be seen that because they were so minuscule. I had so much of data, so much of information. The knowledge and wisdom that I got from all those, a big zero. I was not able to act on any one of them. Over the span of 2 decades, these 120 are now down to 40 indicators. And these are the 40 that we monitor across the network. In addition, every department has been told to monitor 2 or 3. We tell them, don't take a huge list. You want to monitor indicator, monitor them. And I'm not saying that it is again, review them, revise them. You have met the target. 2 or 3 years down the line, you stop monitoring that indicator. Look at a fresh set as to what you would want to monitor. And that's the way, say, the key thing is keep it practical and not ideal, because many of us run behind this ideal number, and Professor Google makes it more difficult. Because, and when I say Professor Google, you Google out an indicator for my department. I'm a pulmonologist. If I say quality indicators in pulmonology, Professor Google will give me 100 odd indicators. And I'm a Control-C, Control-V expert. I know how to copy and paste. So I will copy the 20 most attractive ones in that list. And then what do? Wow, I'm monitoring 20 indicators. What happened after that? Don't ask me. So I think the key thing is to be practical and again see as to why I require those indicators and come up with a defined methodology. That's what I would say from our experience. Thank you.
Thank you so much. Ajibike, anything from you on this? Mistakes?
Well, I mean, there are several mistakes that one has made over time that, it's definitely some of the ones that Dr. Anand has talked about. But the other mistake that we make when we look at data is to forget that there are human lives that make up that data, right? So you say, oh, hospital-acquired infection, we have a target of 0.5. So who is in the 0.5% that is okay to get an infection, right? Is it, if I go for surgery, am I happy to be the 0.5% that gets that infection? So when we look at data from the point of view of the human beings, the human lives that are being impacted, then I think it makes a difference to how we engage with that data. Okay. And then also too is, like I said, we make data say what we want it to say. So we're afraid. Sometimes, we're afraid to go before the board to say our CSAT level, our customer satisfaction level is 76%. We don't want to go before the board. So we would rather slice and dice the data in a way that would make it seem like it's 96%. Let us tell them, let's take our data for what it really is and then work towards improvement. The mistake will be if you see the data, but you're not working to improve it. And then the final thing will be doing a proper root cause analysis. Don't stop at one why, especially if you find out one person who you can hold accountable and say, so you are the person that's been causing us a problem. Why don't we really do a deep dive, a real root cause analysis to see why we are not where we want to be, so that we can come up with solutions that will get us to where we really need to be.
Thanks a lot, Ajibike. Aafke, anything from you? Any tips, any advice how to avoid mistakes, and what are these mistakes?
Yeah, I think with data, it's always less is more, really about defining, linking to outcome, what did we really need to change and want to change in our hospital. And I think we made one of the mistakes is that we have, of course, a lot of data. And last year, we thought of a new dashboard, and somebody really started with getting all the data points. Nobody used it. But then we really try to stick to the main important points, and then went to all the stakeholders, the people using it. What do you want to see? Is this what you want to see? So it's really about co-creation of the dashboards and thinking together, collaborating, not one person thinking, okay, we need to see all the data there. That's not working.
Thanks a lot. That's excellent point. Team approach. And that's what we keep repeating. Use team approach, ask each other's opinions, and then it becomes just more effective because you see the situation from different angles. And if you're a leader, if you are head of the department, interact with the frontline staff. They always know which is best for them. So work together. This will be the conclusion, how to make it really work. So the next question is a very practical one. And Dr. Anand already touched this point a little bit, terminology. How to make sure that every department is measuring some indicator the same way, especially if we're talking about falls. Falls is a great example. What you consider a fall? When the patient is totally on the floor, when the patient almost fell and just sat on the chair because he felt dizzy, when the patient just on the knees, is it a fall or not a fall? So how to make it consistent in a hospital in different departments and in the chain of hospitals, which is even more tricky.
So Julie, as to what we have done is what I touched upon. We in our template have defined as to what a fall is, and we have defined and gone a step ahead and given a reference for it, because one of the key things which is important, and it is important to get your clinicians and nurses on board. Why are we using this particular definition? They will say that, no, I have got a better definition. Why aren't you using that? So it's important not just to define it, but also to give a reference and the basis for using that. And what we do is when we have our orientation programs or when we induct people, we explain to them over training sessions as to why is it a particular thing meets the criteria or not. And we use the same illustrative examples that you use. What if scenarios are given? Let's say that this happens. Would you say that it's a fall, or you would not categorize it as a fall? So by doing the steps that we have used is define it, give a reference, and use what if scenarios to bring in uniformity in the way a particular thing is defined and captured. Thank you.
Thank you so much, Dr. Anand. Very useful, very clear. Ajibike, anything from you on this? Okay, Aafke, anything from you on the terminology, how to make it consistent, how to make it clear?
Yeah, I think that's an important thing. You can have very long discussions about one definition, while it goes on about something else, where you want to go to. So how we usually, of course, within SafeCare, we have our scoring guidelines. That's something that is created as a group together with the assessors. But I think as a hospital, you can also go to the experienced partners. Look at, for example, your country. Usually your country has, for certain things, definitions, and it's very good to align with those definitions. Otherwise, look at WHO, other organizations who have definitions to align to that. So that makes it consistent, and I think there has been a lot of research to those things. So use that research.
Wonderful, thanks a lot. And from me, I wanted to add that if you want to benchmark yourself with some other companies, really look for public resources and find definitions there, and then you will be on the same page. So I wanted to say that we will be wrapping up soon, but before that, one more question, again, very practical, because just we received it several times today, and it again relates to terminology, indicators and KPIs. Is it the same? What does the KPI stand for? And can we use KPIs for indicators, or is it really like performance indicator of efficiency of staff? So terminology, let's clarify this. Thanks a lot. Ajibike,
I just posted
Anand?
a reply in the chat, and I'll just, it's a play of words. That's what I personally feel. It's just that someone wants to give more importance. This is my KPI. But in the usual parlance, we are used to KPIs in HR. We're used to say that these are your KPIs. These are individuals. This for an individual, these are the KPIs. But if I look at it in a much broader way, what is the difference between a PI and a KPI? It is the key. And what is that K? It's all about being the key thing. So if an organization wants to focus on certain aspects, I may monitor 40, but my top management say, I don't have the time for 40, because that's also something which was coming up in the chat box. I don't have the time for 40. You summarize it, you crystallize it, and tell me the 4 or 5 which is important for me, from a business perspective, from a quality perspective, from a safety perspective. So I will narrow it down. And that's actually what we do. When we do our presentations to the top management, the 40 that we monitor gets crystallized down to 12. And we call the 12 as the key performance indicators across the network that the top management should be aware of. So this word KPI could be different. See, when I look at a KPI from an organization point of view, it may not necessarily be this 12. But in simple words, yes, having a KPI would bring in a more of focus. But my personal opinion is we are emphasizing too much on the K. As long as you've got those indicators proper, you're monitoring them properly, whether it's a KPI or a non-KPI, it doesn't make much of a difference, because the goal is improvement. The goal is improving the quality of care and ensuring that we provide safe patient care. Thank you.
Thank you so much, Dr. Anand. Ajibike, you wanted to say something.
Yes, you're very right. Play on words. I remember that, it took me a while to be able to tell difference. KPI, measures, metrics, indicator. I mean, you see all those things and it's all jumbled up in your head. What you are looking for is, how do I know how I am doing? Whatever word you want to call it. And then you find out that the Americans use a phrase, the particular jurisdiction uses a phrase. The important thing is, how well are we doing? And what is it that tells us how well we're doing? Related to the other previous question, we will share with you our template for being able to define your indicators clearly. The most important thing is be sure of what you're monitoring, because if you're not monitoring, if what the data you're collecting is not correct, then you will be interpreting wrongly, right? They ask you what the color is, you say hot. Well, maybe there's hot pink, but they're asking about color, you're talking about temperature, unfortunately, because that's what you're feeling, because all you have is a thermometer, right? And they're asking you about color, and then you're putting in your thermometer and you're saying the weather is, temperature is 33 degrees. Making sure that you understand what you're going to collect. So indicators, measures, key performance indicators, they are all about the same thing. Like Dr. Anand said, people use key because we want to make it sound important, and these are the main things that we're looking at. So don't worry too much about what it's called. Worry more about what it is doing and what it's showing you.
Thanks a lot, Ajibike. This is a wonderful concluding point. And I think it's time to wrap up now. Unfortunately, we are running out of time, although it's such a pleasure to interact with you.
So Julia, sorry.
Yes.
I I got 2 questions sent into my private phone from people who want to know about the cost of the SafeCare tools. And we already have some in the questions as well.
That's the point I was going to make. Actually, yes, Aafke, go ahead, please.
I saw that right as you said it as well. So for us, this self-assessment tool is really to incentivize quality. So you can access it free of charge. Of course, if we need to go there somewhere, if we do need to do an on-site assessment, you can, in the presentation, my email address, just contact me and we can look where you are, and if one of our assessors can assess the facility and help you to improve. But also in the presentation is the URL to the self-assessments, and I hope many people will use it because it will help you get a start with improvement and measurement of quality.
Thank you so much, Aafke. That's exactly the point that I was going to make. There are contacts in the presentation, and you can ask any questions relating to the tool straight to Aafke. So thanks a lot to the audience for staying with us. As usually, a little bit longer than we planned, but it's a pleasure to share this knowledge. Thanks a lot to our wonderful panelists today. I think there's been a lot of energy in our presentations, and this is really important topic. And I hope that the audience found it useful. It's great to have the advice that you shared and lessons from your practical tips from your journey. So have a great evening to everyone, and thanks a lot. Natasha, did you want to say something to conclude? By the way, sorry, just to remind you that you can also post your questions and find answers to the questions in our community of practice on Facebook. That's number 1. Number 2, we do hope that you will join us for the next webinars, which will also relate to data collection. It will be clinical indicators next time, and then benchmarking the one after. And now over to Natasha if she wants to add something.
Yes, of course. Thank you, Julia. I have internet problems, so I cannot switch on my video. What I would like to ask you is to fill out the survey on an exit when you exit the Zoom. That way we can receive all the feedback that you could provide, and we will be very grateful because your feedback is what powers us, what tells us whether we did good, whether we covered the right topic, and what are the topics that we need to cover. So please do that. Don't ignore it. And you will be receiving the slides from today's presentation and the list of our resources by the end of business day tomorrow. Thank you very much.
Thank you, everyone.